Hi everybody, this is Dr. Peters and I'm going to be talking to you about rheumatology and basic rheumatology today. By no means are you going to leave as an expert on this. We have rheumatologists out there, but it's very important that you understand and know the signs, symptoms to at least gather number one, to understand when you need to refer a patient, and number two, to consider when you're going to get this basic lab workup and to identify some of these symptoms to say, this is not just your typical ache and pain. Rheumatological disorders can be very difficult to diagnose because there's many of them are diagnosis of exclusion, or there's not a specific lab test to diagnose them. And when someone comes in with joint pain or joint swelling, that could be, there's many differentials for that. So you need to determine, is this inflammatory or not inflammatory? Is this acute or is this not acute? So I'm going to go through the most common that you'll see in primary care. There are obviously multiple rheumatological disorders out there, but again, it would take a whole semester or quite a long time to go through all of those, but we need to know the basics, and that will be a segue into the other rheumatological issues. The other thing is I will lecture also on the Family Nurse Practitioner Review Manual. This is by the ANCC, so I always take tips out of here because I want to make sure you're prepared for the certification exam. As far as the AANP, they use a lot of the same tips for your main didactic portion. I also have the Barclay certification review, and so I go and look to see what exactly is important for you to know for that, as well as I bring things out for you that you need to know in practice. So the main things I'm going to talk about, which I'll get my Panopto or my PowerPoint going, but one more thing is I'm going to be referring to some specific websites. And if you can't read it or can't see it, there is an ability for you to go ahead and make your PowerPoint screen a full screen. So there should be a couple arrows in the corner for you to do that if you don't know already how to do that. And the other thing, I will be providing you the reference for all the links in here, okay? So let me minimize. Actually, I can get out of that, and I can get out of that. And we'll get started on here. All right, so I'm going to start my slideshow. All right, so the only thing that you have to look at is the polymyalgia. It's not arteritis, it's polymyalgia rheumatica. So rheumatoid arthritis, lupus, fibromyalgia, polymyalgia rheumatica, or PMR, and giant cell arteritis. PMR and giant cell arteritis go together hand in hand. They have a very high incidence of having giant cell arteritis if you have polymyalgia rheumatica or vice versa. When you think of temporal arteritis, maybe you've heard that more. That's giant cell arteritis. That's an inflammation of the artery. So we will be talking about that. I'm also going to be talking about when to refer and some treatments for guidelines. So first we're going to be talking about rheumatoid arthritis. All right, so I'm going to compare it to osteoarthritis because it's easy to do that and try to figure out what's non-inflammatory versus what's inflammatory. So your morning stiffness. So someone with rheumatoid arthritis, you're not just going to get up in the morning and move around a little bit and then have it go away, because when you have an inflammatory disorder, that's going to last through the day, and inflammation doesn't just go away an hour after you get up. So these are the people that are having significant pain throughout the day, and as they keep moving it, think of if you have inflammation, say in your shoulder, if you have tennis elbow or anything like that, there's inflammation in there. So the more you're using it, the more pain you're, going going to have. And then also when you're resting it, you still have that inflammation in there. So you are still going to have pain. So think inflammation is you're going to have that continuous pain. So when you are comparing non-inflammatory versus inflammatory, versus non-inflammatory, look at this chart here. Any of these charts you can print off and keep with you for your references. I squared off the most common. So morning stiffness is very common. It's prolonged in rheumatoid arthritis and lupus. Where with osteoarthritis, it usually goes away. Someone has a stiff back, spinal stenosis, for example, or just common arthritis. They'll get up in the morning stiff, and then when they start moving around, it gets better. And then their peak period of discomfort is after prolonged activity. So someone who's sitting for quite a long time, you'll see more rheumatoid arthritic patients have a lot of pain. And then the inflammation, fluid, tenderness, warmth, erythema, and synovitis is common with inflammation process versus the non-inflammatory disorders. So osteoarthritis is very common, and as we age, we'll see it more and more just because of the aging process. We really don't know why people get osteoarthritis, but it's usually from the aging process, and it is a second leading cause for disability, and it's usually in patients 60 and older. And so what happens is we tend to not necessarily slough off the people that are elderly and have joint pain because we think, well, everybody has osteoarthritis. Everybody's got arthritis when they're older. But it's up to us to just make sure that it is a true osteoarthritis and not more of an inflammatory arthritis, and we're not missing something. So when you look at the distribution of osteoarthritis, and I'll show you one for rheumatoid, you can see here that the distal phalanges it affects, and I'll show you a picture, and you'll have the Herberton nodes and the Bouchard nodes, and I'll show you a picture of those. Those are nodes that develop, and they feel very hard as compared to if you have rheumatoid synovitis, that's soft and spongy. That's the difference. And rheumatoid arthritis will be more your proximal phalanges. And then osteoarthritis, people usually have a lot of knee, greater trochanter hip, the ball and joint there, and pelvic spinal issues there. So you hear people having hip replacements, knee replacements, and then the spinal stenosis, and then going up in the neck area. So many times I get x-rays, and it's very common for patients to have a spinal or degeneration. It'll come out, read out on the x-ray. Degeneration, degenerative disease, degenerative disc disease, that's all arthritis, and it's very common. And that brings up the Bouchard's and Herberton's nodes. So if I can read this here, I have to read it up close. So if you look here at some pictures at some arthritis symptoms. All right, so these are osteoarthritis. The man is leaning over. He's got probably some spinal stenosis, most likely, because he's leaning over. The top left of the hands, you can see the Herberton and Bouchard nodes. The Herbertons are the ones that are most distal, and the Bouchard nodes are the mid interphalangeal joints there. And then if you see on the right, well, she's got some major bunions for sure, but there is some osteoarthritis, and it's pushing that toe over. The one on the right lower, this one I'm thinking is a shoulder. I'm not sure what that is. All right, so, but just to give you the idea of what osteoarthritis looks like. You can support the diagnosis by x-ray. So if you're not sure, you can get an x-ray. If they come in with pain and you're seeing these nodes and you can suspect that it's probably osteoarthritis, you can just get a simple x-ray. If they have gout, usually gout will show up as gout on the x-ray. We're not going to talk about gout in detail this time, but I know you went through that in APN 1, but with gout, the true way to diagnose is to get an aspiration. Now, rheumatologists do that, primary care, is that reality? Very few primary care doctors will do the aspiration. We get uric acid levels, and usually we'll see that more in the lower extremities. But again, we're not covering gout for your exam or anything like that. But it's good to have an idea of all these different types of joint issues, so you can say, okay, well, that looks more like this and not like this. But if somebody has these Bouchard nodes, it right here and then the distal, and it's hard and it's not soft and spongy, it's most likely it's an osteoarthritis. You can certainly get an x-ray and they'll tell you, it'll read that it's degenerative disease. You have some degeneration in the joints, so that's will be most consistent with the osteoarthritis. You can also, if you do suspect it can be some inflammation, you can always get a SED rate, which is an inflammation marker, and a CRP, which is another inflammation marker. And I always tell people, or my patients, that it's a check engine light. It means that if it's elevated, that means you have inflammation going on somewhere, but it's up to us to do the diagnostic check to figure out, well, where is this coming from? So if someone's having multiple joint pain and their SED rate's elevated, it could be most likely coming from the joint pain. So that's when I say it's the check engine light comes on, then they understand that it's just a broad laboratory to get. As far as treatment for osteoarthritis, usually it's analgesics, NSAIDs, and COX-2 inhibitors, which is Celebrex. And you have to be very careful with these analgesics now, or even in the past, but it's just become more mainstay as precautionary because of GI bleed and cardiac issues such as heart attacks. And so we have to just be very careful. And what's difficult is the elderly love their NSAIDs because it helps them. Tylenol doesn't do anything. And we certainly don't want to give them narcotics. So we really have to try to focus on the non-pharmacological approaches, because what we try to tell them is strength training is so important, even if they have cans of soup in their house, or that has some kind of weight to it. That's very important, because I tell them you have your bone that's has some arthritis in it, so it's degenerating. It's aging. So what you need to do is you need to strengthen the muscles around the joint to reduce the load on that joint. So I try to tell them, and I'm talking about hips, I'm talking about knees, because if your muscles are weak around the joint, you're putting so much pressure on that joint. So that's what I try to explain to them, that's really number one. And the pain relief is helping it and helping to put a Band-Aid on it. So, and the glucosamine works really well. There's some great studies out there with some good evidence that says that glucosamine is beneficial, especially for knees. And then, of course, if it becomes severe degeneration, bone on bone, that's when joint replacements you'll hear about, which is common. It happens. People have their total joints replaced of hip and knee. Don't hear too much of hands and elbows, occasional shoulder. Usually those are people that have had chronic issues through the years. They've had rotator cuff repairs and that kind of thing, and then they've just developed a lot of osteophytes and developed osteoarthritis over time. And the failed conservative measures. These are people that have gone through corticosteroid injections, the Hyalgan injections, whatnot, other treatments out there in physical therapy. Another thing is, think about weight. Obesity is really prevalent now, as we all know, and they're putting a lot of pressure on all of our joints now, so it's a huge issue. Here's some arthritis here. So on the right is non-inflammatory, and on the left is an inflammatory. So I can tell the difference. On the right, it's more bony, and on the left, you can see where there's some softness to it. It's more spongy. Psoriatic arthritis, you have psoriasis, but it's an autoimmune disease, so it's really an internal issue. So that's another thing, when someone has a rash that looks like a psoriasis rash, you have to think, did they have any joint pain, joint stiffness, because you have to keep that differential in the back of your mind, the psoriatic arthritis. This is to give you an idea of what is under inflammatory arthritis. You have rheumatoid arthritis, which I am discussing. You have your ankylosing spondylitis. You have psoriatic arthritis. You have reactive arthritis. So there's a type of arthritis that's more inflammatory, and an enteropathic arthritis, which is very uncommon. So as far as exam purposes, you need to talk to Dr. Humphreys about that. But she knows I'm going over the main parts of what my slideshow is. So, and I will be going over the SLE stands for lupus, and then there's Sjogren's, scleroderma, the connective tissue disease, polymyalgia rheumatica I'll be talking about, vasculitis, infectious, and other connective tissue diseases. Now, I wanted to put this in the slides for you just so you can have a grasp in your mind of what is inflammatory arthritis, because think of it as an umbrella and you have all these things underneath it. I am going to go over the most common that we see in primary care. Okay, your rheumatoid arthritis, your lupus, polymyalgia rheumatica, and your temporal arteritis, which is part of vasculitis. And then this is just another table that includes the inflammatory as well as your non-inflammatory. So your non-inflammatory is going to be your osteoarthritis. But I'm going to be going over inflammatory today. Now, inflammatory also includes other major things that aren't included in my talk today, which also includes things that that can overlap with other specialties such as sarcoidosis, which is more of a pulmonary issue. So I'm not going to be going over that at all. So now I'm going to focus on rheumatoid arthritis. I'm sure many of you know somebody with rheumatoid arthritis, or perhaps it runs in your families. You can see it's a genetic gene. It's a gene specific, and it doesn't mean that if somebody, say your grandma has rheumatoid arthritis, doesn't mean you're going to get rheumatoid arthritis, but you can get the autoimmune disease specific to that gene. So there's specific alleles in that gene that you can end up getting, like Graves' disease, or I'll use an example. My grandpa had diabetes type 1, so my sister has multiple sclerosis and Graves' disease, and her daughter, my niece, has celiac disease, and it all comes from the same gene. So that's what happens with these autoimmune diseases. Rheumatoid arthritis, it could just keep going down the line, mom, daughter, but there's also still other autoimmune diseases that can run down the line, usually occurs in women. And when we think polyarthritis, we think multiple joints. You don't come in with, it's usually not somebody coming in with just one elbow. It's usually not asymmetrical. It's bilateral. It's polyarthritis. They're going to have more than one joint, and symmetric. And here's the other distribution. Remember the osteoarthritis? Remember it was the the lumbar spine, and it was the knees and the hips and your distal fingers. Now look at this. It has more joints involved, okay? And it has your more proximal joints. It still includes the neck and the knees, but you can see it includes your feet, those joints, your elbows, your shoulders, your wrists. So it's many more joints that are involved. Okay, so this is where, and I'm going to look at my other screen because it's bigger. This is an algorithm that will help to help you work through what a good workup would be. So if somebody comes in and they have multi joint pain that's symmetrical, you're going to obviously do a complete history and physical exam. And history taking, which I'm sure you know by now, we learned last semester that history is like 80 to 90% of gathering a good list of differentials in your mind. And then, but with rheumatology, your physical exam is really important because you're trying to see if there's any synovitis. You're going to be feeling, so palpation and observation is very important. So, is there synovitis? And again, synovitis, inflammation of the synovial membrane in the joints. That is what that is. So, when you're feeling it, the difference is it's spongy feeling. It's not like crepitus, but it just is spongy, like it'll kind of bounce off a little bit, but it's spongy. So it'd be good if you had some experience with that in your clinicals or know somebody that has that. So is there synovitis? But if there isn't any synovitis, okay, you can pretty much say, well, I'm not really so convinced at this point that it is a rheumatological issue. So let's go over, are there tender points? Let's just say that you're touching, the elbows, and they're going, that really hurts right there. Oh, it really hurts on this side too. That really is hurting. Or you're touching their greater trochanter area, and they're saying, ow. Then you're thinking, do they have some bursitis? Do they have some tendinitis or fibromyalgia? So when we go further in the slides, I'm going to show you the tender points for fibromyalgia, but there's specific tender points for that. When you're thinking greater trochanter, bursitis, very common in that area. People come in and they'll say, I've got hip pain. A lot of times on my schedule, they'll say hip pain. And they come in, and I think the patients don't understand that their hip is really in the groin. That's where the ball and joint is, right? So I'm thinking ball and joint right here. Well, here's the greater trochanter and the femur, and really their pain's right here. So it's not really the ball and joint, and everything's moving well, and they have great range of motion. But then when I'm touching here, where the bursa is, they are in tremendous pain. So they really have inflammation of the bursa, which is very common. Or do they have tendinitis? It depends on where it's at, what joint it is. If they don't have any tender points, then you can, if they still have, let's go back, they came in with multi-joint pain. Then you think, well, maybe this is a virus that's going on. You also have to think how long this has been going on. Do they have osteoarthritis? Is this a soft tissue thing and not a joint thing? And hypothyroidism always comes into most areas. So that's going to be always part of your basic lab workup. And do they have neuropathic pain? So are they having numbness, burning, tingling in the lower extremities? Or is it depression? Many times with people that are depressed, they have some psychosomatic issues, which is bringing on, they have symptoms. It's not saying that they're making up their symptoms whatsoever. It's just that's the depression and the pain receptors are related. That's what we found. So then you would consider getting these tests here, because those would be your differentials. But let's go back to our initial thing. Let's just say we're feeling a joint and we're like, gosh, that just feels weird, or it's just not something that feels right to me. And they've had these symptoms for a while, of greater than 6 weeks, let's say, because you have to remember 6 weeks is your chronic to acute cutoff. All right, acute 6 weeks, it becomes a chronic thing. If it's less than 6 weeks, like it says, let's say it's been 3 weeks, then it's like, well, maybe they have a viral arthritis, because there's many viruses out there that can cause polyarthralgias with synovitis. Or do they have an early rheumatic disease coming on? So you want them to follow up really closely. I'd have them come back in a week, and then a week after that, until symptoms are either gone or they haven't gone, and you want to start getting a workup. But you want to check some blood counts right away anyways. But let's say it's greater than 6 weeks. So going down the rheumatological road, they have polyarthralgia, synovitis in any joint. Okay, you're thinking symmetrical, that something's going on both sides, and it's been going on for, say, 2 months. Then you're thinking, I'm suspecting rheumatological disease. So here is your workup here. You're going to get a CBC sed rate, rheumatoid factor, an anti-nuclear antibody, a creatinine, joint aspiration. Now, you would not do that working in primary care unless you're taught to do that. But if you're taught to do that, which many of us are, go right ahead and do it. Rheumatoid factor, the specificity isn't very high for it, but it's part of the workup. I also want you to write down the anti-CCP antibody. That is it's an antibody that's very specific to rheumatoid arthritis. And if that's elevated, the sensitivity is very high on that. So if that's elevated, that pretty much brings you along the road that they most likely have rheumatoid arthritis. The ANA, the anti-nuclear antibody, again, the specificity is pretty low on it. But again, it's a good marker. It's a good marker for lupus, actually, but it's a good marker for autoimmune issues. But just remember, if the ANA is negative, it doesn't mean that they don't have rheumatoid issues. If the rheumatoid factor is negative, doesn't necessarily mean they don't have rheumatoid. You would be referring, and I'm going to go through that when to refer, okay? There's a fine line with this, so it may sound a little bit confusing, like, okay, do I get this workup or do I not get this workup? In the beginning, you may not feel comfortable getting the workup, or you may work with a collaborating physician and you go ahead and get the workup, or you will just refer. It will just depend, number one, where you work. Number two, are you going to follow the guidelines and just refer once you're more comfortable? Or number three, maybe the rheumatologist wants you to get the initial workup. Call them up and ask them, hey, I've got this patient that has these symptoms going on. Would you like for me to start the workup? I can get this lab, or do you want me to just refer them to you? And they will tell you what their preference is. I've done that many times. This is just another slide to give you an example what's inflammatory versus non-inflammatory. And don't ask me about that first slide, but that's the one that came on the specific link I'm going to send you. So anyways, fibromyalgia. There's specific points, and when I talk about fibromyalgia, I'll go into more specific details about that. But there's 18 tender points on fibromyalgia. Osteoarthritis, there's the main points versus rheumatoid versus gout. These are most common. I'm going to go to a really nice exam website, and this will be available for you. Again, try to make your screen bigger if you can, but again, I'll provide the link for you. But I'm going to go down the line here. It tells you how to take a history for a rheumatological issue if they come in with joint pain or joint symptoms. But what's nice about it, on the right-hand side, it'll tell you exactly, what movements to do, and it'll go down each joint, like the hand, the wrist, and it'll tell you how to do the exam of each one. It's really nice. even for ortho exams, it'll do the Finkelstein's test for de Quervain's. I know we're not talking about that, but just for your own reference, it'll go through the elbow, the shoulder. So I'm not going to go through each one in detail, but I did not want to forget to show you this. And then this is really nice because it goes through different differentials for you. Okay, so I'm going to get back now to my next slide. So common treatments for these are, as far as medications, I wanted to go through these with you that you'll see patients on. Now when it comes to rheumatoid arthritis, you will be referring, and then they're going to be, the rheumatologist will be giving the patient prescriptions. A lot of times you'll see patients on NSAIDs, and you want to always make sure that this is prescribed by the rheumatologist, and you want to watch for side effects, GI effects. Are they on a proton pump inhibitor such as omeprazole or Acifex or Prilosec, any of those? They should be on one of those if they're on chronic NSAIDs. More or less, though, with the rheumatology, the motto is treat to target, so you definitely want, the rheumatologists are really trying to be more aggressive with treatment, and they're treating with some of the newer medications, and they understand that there's a lot of side effects to some of the NSAIDs now. As far as steroids, they try not to treat with steroids unless it's absolutely necessary. Because remember, steroids have a lot of side effects too. There's the DMARDs and biologics medications. DMARDs stand for disease-modifying anti-rheumatic drugs. So you'll hear DMARDs. So they can slow the progression, and also they can help save the joints from permanent damage. So they can, slow it down, basically. So when you hear methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, many patients are on a combination of a DMARD and a biologic, which I'll show you the guidelines, and then you can have access to that too. There's also biologic agents, and these are the newer class of DMARDs. Okay, so these also slow the progression. And that is your Orencia, Humira, and your first ones out were Humira. There's Remicades been out, but Enbril's been out for a long time. Xeljanz. So these drugs can target the immune system. So they trigger information. They trigger inflammation and inflammation that causes joint and tissue damage. They can also increase your risk of infection. So they lower your immune system. So you have to be very careful with these medications. So this is what's really important working in primary care. If you have patients on these medications and they have a cold, they're ill, you may want to talk to the rheumatologist to have them hold their medications for a while. It's usually the biologic agents, and they usually will keep them on the more of the leflunomide, methotrexate. Usually they'll keep them on that. It's more of the other agents, such as Humira, because it has such a higher incidence. They also get tested for TB. They need to be tested for tuberculosis before they even go on it. There's an algorithm in the guidelines to tell you how to test for TB. And also, anytime, please just put this on pause and take a break, because I know it's a lot of information. Now, there's also called the anti-TNF, which is your tumor necrosis factor agents, or anti-tumor necrosis factor. It's a factor that you have in your body that causes inflammation. So it helps target that specific substance called tumor necrosis factor. So it helps to control the inflammation in the joints, but it also helps within the GI tract and the skin. So sometimes you'll see people with Crohn's disease beyond some of these medications, such as Xeljanz. Also blocks the body's production of enzymes called Janus kinases, or JAKs. They play a role in joint inflammation and rheumatoid arthritis, which can cause pain, swelling, and stiffness. Oops. Okay, so I'm going to go to another website here, and this is an awesome website. If you even don't know about a medication, or if you want to bring up something for your patient, it's from the American College of Rheumatology. And if you look here, you have rheumatologist, health professional, these down here. You can make your screen bigger. Hope you can see it. If not, I'm going to provide you the site. But you can go down and pick any single remedy, medicine that's used for any type of rheumatological disorder, and it'll tell you what it's used for. So if you, like for example, this is Orencia, and it is for moderate to severe rheumatoid arthritis. It's often prescribed after failure of a DMARD, such as methotrexate, but it can be used as first-line therapy. And it goes through the entire thing. So it'll tell you exactly what every specific medication is. The other thing is you can click diseases and conditions. And it'll tell you exactly everything you need to know about diseases, conditions. Say, let's go to anti-nuclear antibody. And it'll tell you exactly what it is. How do you test? How are they measured? What does it mean? And how do you handle a positive read? All right, so like for example, again, we're going to be talking about polymyalgia rheumatica. It'll go down the line about facts. What is it? What causes it? How's it diagnosed and treated? And living with polymyalgia rheumatica. So it's really nice. And then another thing about treatments. If you're not even sure, you can go down, say you have somebody on, let me just pick one that's more common here. Let's say you have someone on Plaquenil, because we see that a lot. There's even herbal remedies you can pick, because some people come in on those. A lot of people do. Okay, so that's your hydroxychloroquine. It's used to treat mild rheumatoid arthritis or in combination with other drug. You can do uses, how it works, your dosing, and it says generally how it's dosed, time to effect, side effects, drug interactions. All right, so this is excellent. You can use also, now this is just for the patient and caregiver. You can go to the health professional and it'll give you some resources and education. I ended up taking the advanced rheumatology course because I was seeing rheumatology follow-ups with the rheumatologist. So I have that certification. It took me about 6 months to finish it. All right, so I'm going back into my thing. All right, so let's talk about lupus now. So you might want to take a break and come back to this, or you might want to get it over with, right? Okay, so lupus. It's inflammatory again. We don't even know. It's unknown etiology. It's some sort of immune thing. But we think it's autoimmune. So basically your body attacks itself. So excessive autoantibody production, some of which cause cell damage. So, and the other cause inflammation. So that's lupus. And the features, the problem with the lupus can be mild. Someone can go their whole life with mild lupus. But it can be very devastating. Somebody can, because it can attack the inflammation. You can have inflammation of your kidney, brain, heart, GI tract. And if you have inflammation of, say, your kidney, you can have kidney failure, and which is more common with lupus. Organ systems are involved, and we see the kidney involved more commonly if it's going to be a major case. Central nervous system accounts for significant morbidity and mortality because of tissue damage due to the disease process. So this is how we classify it or diagnose it. So it's a SOAP Brain MD. And a person shall be said to have lupus if 4 or more of the 11 criteria are present, serially or simultaneously. So you can look, and they don't necessarily have to have positive ANA, but it's 4 or more of the 11. And so they can have ulcers, arthritis, photosensitivity. So again, sometimes it's difficult to diagnose. So you're looking at their blood disorder. Do they have any hemolytic anemia or leukopenia, thrombocytopenia? Are they having seizures, a rash? So early on, or if they have a mild case, sometimes it can be difficult. Some people think because they have a malar rash or butterfly rash, they have lupus, but it could be just rosacea, but it's just something to look at. So here's a picture of a man who has lupus. He's a 53-year-old. He has weakness, weight loss. He's got psychosis. He's got alopecia, malar rash, arthritis, psychosis. And if you look at his labs here, he's got proteinuria. His SED rate's elevated. His creatinine is elevated at 1.4. What else does he have going on? So when you're looking at labs here, now these are going to be rheumatological labs that rheumatologist is going to get. So you have the CH50 and the C3 and C4. These are complements. Complements are basically a breakdown of your immune system, and they fight off infection. And so C3 and C4 are most commonly seen decreased in lupus. So basically, if you have a decrease in the complement, that means that you have a break in the complement chain. You have complements 1 through 9. Now, this complement 50 is more so of a panel, so it's looking at the whole panel. And as you can see, the panel is low, and so your body's not fighting off, or it's not. It has to do with your autoantibodies and the antibodies in your system and your immune system. And so C3 you can see is low. So there's a break in that complement chain to fight off infection, to help your immune system as well as your antibodies. So your ANA, his ANA is elevated. And there's an anti-double-stranded DNA, and that has to also do with antibodies. And we'll talk about that. It's a group of autoantibodies that are produced when your immune system, when a person's immune system, it fails to distinguish against yourself and your non-self. So basically it attacks yourself, and they're autoantibodies. The anti-double-stranded DNA targets the genetic material that's found in the nucleus, and it causes organ and tissue damage within the nucleus of the DNA, but it causes organ and tissue damage to that specific organ. So if you have inflammation in your kidney, what could be happening is this double-stranded DNA, it's autoantibodies. It's destroying the nucleus of each of the cells, and then therefore it's causing inflammation, and it's damaging the tissues in that specific organ. So it's strongly correlated with lupus. And then you have direct and indirect CUMs, and indirect CUMs we see more when a woman and a fetus, when their blood types don't match, but a direct CUMs is more seen in lupus. And here it describes what the anti-double-stranded DNA is. It's the antibodies, again, that I already described. And then the complements, which I tried to explain in a layman's terms. It's used to determine whether deficiencies or abnormalities in the complement system are causing or contributing to a person's disease or condition. A total complement, which was seen a couple slides back, may be ordered to look at the integrity of the entire complement pathway. And then there's the Coombs test, and I put everything. So just to give you an idea that a Coombs test is not just specific for lupus. It has to do with your clumping of your red blood cells. So that's why I brought up the indirect Coombs, because when you think when your blood's not compatible, like a fetus versus the mom, you're going to have that clumping of red blood cells because it's not going to be compatible. It can destroy them. Okay, so I'm going to go to an article here about lupus. All right, so as far as this goes, also this you should read as part of your assignment for this week, and it goes through here the overview, the presentation, differential diagnosis, but the workup of it is it's going to be basically the same as like a rheumatological workup for rheumatoid arthritis because this is all autoimmune. So you're going to get your CBC and creatinine and urinalysis. You want to look because are they leukopenic? Remember those, if you go back to the slides, you can see they can be leukopenic, their white blood cells can be low, they can be thrombocytopenic, their platelets can be off. So you want to check for anemia. You can screen for kidney disease. Do they have protein in their urine? Also, do they have inflammation and complement levels? These are just things to keep in mind. Now, you can get basic levels. You don't have to go ahead and get complement levels right away. For you, being a new nurse practitioner, again, it's just going to be that choice, whether, number one, you're going to go to the rheumatological guidelines on when to refer. Number two, you're going to talk to your rheumatologist and see what they want you to get. But the least you can do is a CBC, a metabolic panel, that's going to have your creatinine on there, a urinalysis, a SED rate, and a CRP. Your liver function, which would be on your complete metabolic panel, although missing bilirubin and that stuff. That's the least that you can get, and then see if your rheumatologist wants you to get any more if you're suspecting that. But what's nice is all these autoantibody tests are at the bottom. All of these are what, and also you can get a rheumatoid factor and an ANA. And if you're suspecting rheumatoid arthritis, you can get the CCP antibody. If you're suspecting more lupus, then you wouldn't get that. But the ANA is really specific for that. Otherwise, you would get these other labs. But rheumatology usually will get that. Okay, so, oops, let me get this out of here. So if you're not a member of Medscape, you got to join. Okay, so when someone has lupus, this is when it becomes a multidisciplinary team, because if they have multi-systems involved, then you need to use many of these. Not all of these for every patient, but you'll just have to say, well, maybe we need to consult with the nephrologist because they're having some kidney issues, or a GI doctor, because many patients with lupus have GI issues. And a lot of times that's how patients are first clued in or diagnosed. They have GI issues and they go to the gastroenterologist and they're like, oh, let's check you for lupus, because then they clue in to it. All right, so let's get to medication here. Okay, so treatment, it just depends on what symptoms that they have, but they will treat with the DMARS, which, for example, your hydroxychloroquine, meaning the Plaquenil. Sometimes they'll have NSAIDs, steroids, low to moderate doses. It just depends. It's dependent on the patient's symptoms, and it's dependent on the severity of the disease. Do they have acute flares? They'll use methotrexate. So a lot of times they'll use a lot of the same medications as they'd use for rheumatoid arthritis. So they'll also use other specific medicines such as azathioprine. And then they have to also use cyclophosphamide, and that's or if you have lupus nephritis, which is your kidney disease from lupus. But again, that's going to be from a nephrologist point of view. So these are all things that they will use some steroids in lupus if necessary, but you really wouldn't need steroids for renal damage, hypertension, psychosis. That's really not going to do any good. That's not going to respond to steroids. And this is a nice algorithm to show whether you need to order and how to follow up on a positive ANA. And it goes to both slides here. So it starts here and goes here. But it'll tell you when to order and when to not. So if you suspect lupus, you're done. You don't need to get that. So if you're still saying, how do I suspect lupus or not, go back to this slide here. Go back to the slide right here. Do you suspect lupus? Does this person come in with arthritis? Do they have oral ulcers? Do they have a rash? Any rashes going on? You're not going to know if they have any ANA. You're not going to know. Usually they don't have neurological disorders. You can get a blood count, but usually patients will come in and they'll say, you know, I've got this joint pain, or I read on the internet I could have this or that. You know, and then you just start asking the questions and doing your history. What I found nice when I started, I took lupus and made a template for my rheumatological diseases. So I had lupus, and then you have these written out on your template, and then when you have somebody that you suspect, you can always grab that, take it out, and ask them and check off if they have any of those symptoms. That will help you. It's okay to do that because that's how you learn. Because these can be very hard to remember. And then if you do suspect the rheumatic condition or lupus, then you'll get the ANA test. If they test negative, then you don't need to go further. You can also refer if you're still unsure. If they're positive, then how should a positive be interpreted? Then do they have one of the conditions below? Is further testing indicated? This is where it brings you here. But here you would be referring to rheumatology. All right, so this is where primary care differs from specialty, and this is when you're going to refer. But again, it's also good to know what actually goes on beyond that. All right, so what I'm going to do also is bring you to the rheumatoid arthritis guidelines. This is the 2015 ACR guideline for rheumatoid arthritis. This will be available to you, and this is what you should be using. It goes through and tells you what each of the medications are. All right, so I'm going to get to here, and you should be able to make your screen big, but again, if not, you should be able to look at these online. I'll provide the link. It'll be in your content area. On the left-hand side, it's going to be treat to target. So you want to treat to their symptoms. That's what that means. So these are for DMARD. Remember those disease-modifying medications for early rheumatoid disease? These are for people that have early disease and they've never taken any of these meds before. So if they have low disease activity, it's recommending DMARD monotherapy, so they could put them on like a sulfasalazine or methotrexate, just one, and put them on like a low dose until they have symptom relief. It's moderate to high activity. It recommends either you can put them on one alone, or you can go up to put them on a combination of one of these, which is more recommended at this point. So moderate, or so if this is not working, moderate or high disease activity, we can go down to the other one here. So if someone has established rheumatoid arthritis and they're coming in and they've never taken the DMARDs before, you're going to, again, this is what the rheumatologist will be doing. So it's very important to understand why these patients are on these medications. And if they're on, so when you think of DMARDs, I want you to think of methotrexate. I want you to think of the sulfasalazine, the quinapril. Look back on my slides and see those. Think they can reduce your immune system, but not as much as the biologics. So when you think of the biologics, such as Humira, and again, look at those slides. Those are the ones you have to be careful. If someone's having a pre-op, like I do pre-ops, if someone comes in for a pre-op physical, I always talk to the rheumatologist and we always hold their biologic medications. But we will keep them on the sulfasalazine or the, any of the DMARDs that they're on. Those are usually okay. But again, you always want to consult with them. If anybody comes in with a cough, look, you got to know your TB symptoms. That's their immune system is lowered when they're on those medications. So that's the main takeaway. One of the main takeaways with the primary care aspect of it when they have rheumatoid arthritis is that you're going to need to know what these patients are on, what they are, what are the side effects, and are they taking them correctly. I asked them, do you see a rheumatologist? Yes. How often are you taking this? And they need to tell me how often they're taking this. And so because you have to think of yourself in primary care as the gatekeeper, you're managing everything about that patient. So I want you to just go through this on your own. But right here talks about TB. If somebody is having a two-step test, what happens if it's positive versus negative. So if it's negative, then you can start the biologic or resume it if somebody had been off it before. But if, say, someone's positive, it'll tell you exactly what to do. If it's positive, they get a chest x-ray. If that's positive, they get a sputum. If that's positive, they need to treat them for active TB before they even started. They need to complete the treatment of active TB. And then if their chest x-ray is negative, then they need to, and they have latent TB, then they have to completion of at least 1 month treatment of latent TB. All right. So I'm going to go back to my slides now, but I wanted, let me go to the recommendations to refer, because I'm moving on to fibromyalgia. So these are referral guidelines. So when to refer to rheumatologist includes but not limited to. There's some of these which I would treat myself at this point of the game, and there's many rheumatologists now that do not treat fibromyalgia. We have such a limited amount of rheumatologists in Wisconsin, so I don't know. You'd have to collaborate and talk to your rheumatologist, but there's no reason why we can't treat fibromyalgia. So these are the diagnostic criteria, such as fevers that aren't diagnosed, normal lab studies, but have this generalized joint pain or swelling or something that you just can't explain and you can't figure out what it is. If the diagnostic evaluation and long-term management of inflammatory arthritis, which I completely agree with long-term management. And as far as diagnostic evaluation, you can definitely get a basic workup and even start a more extensive workup based on your comfortability level, and you can collaborate with your rheumatologist. Connective tissue disease, vasculitis, so this is everything that they treat. So it's kind of nice to see everything right here and everything that they treat. Or if you want to confirm a diagnosis and help formulate or participate in a treatment plan for these things, Raynaud's, because we can treat that in primary care. Serum sickness, which I don't really see too much, and or provide a second opinion or confirmatory evaluation requested by primary care physicians. All right, so I'm going to go back to the slides. It probably took me out of my slides, actually. Resume slideshow, yes. All right. It's not bringing me to where I want, so. Sorry about this, guys. I was way down here. Which is good, that means I'm almost done. For your sake, right? Okay. Oh my gosh. Alright, so I'm just gonna make this bigger. I don't know why it's not doing this for me. Okay. Yikes. Alright, so I hope you can see my screen here. Let me try one more thing. Oh, I think I know here. Hold on a second here. Okay. All right, there we go. Okay, so I think we got it here now. Should be able to see my screen.